Thank you first, Viraj, for giving this opportunity. And every time you give me something, I learn a lot. That's the major benefit of doing these things. So I'll just leave this introduction just to tell you that yes, hepatitis B and C virus are one of the most important culprits that we see that we handle when we handle HCC. So to start off, let me ask Viraj first. Can you tell me, Viraj, is there any difference to know whether it's hepatitis B or C? Because as medical oncologist, whenever I see those trials and look at the viral infections, that's the only thing which I look at. Nothing majorly different is different between hepatitis B and C. So you are dealing specially on a specialized unit. Do you think that you look at these two viruses very differently when you look at HCC?
Yes, sir. So we always check for viral status, not for predicting any responses, just that hepatitis B is a poor prognosis and hepatitis C is not so. But we don't make decisions of treatment based on that.
Okay. Then I come to my surgeon because I feel they look at it differently. Is it true to state that when there is a hepatitis B, the liver is more commonly damaged than when there's extensive damage in hepatitis C? And does it make you as a surgeon be more skeptical when you're looking at a hepatitis C, or is it nothing much? And what Viraj told is that's what it is.
See, basically hepatitis B, many of the patients, they will not have cirrhosis in the background, and many of them, they are operable straight away. We see significant number of patients who are, operable. But on the contrary, on hepatitis C, most of them, they have a cirrhotic liver and they are not resectable. So that is what we commonly see.
So this is something which I wanted to bring out because we as medical oncologists don't look into these things. And when we get a surgeon's perspective, then when you look at hepatitis C, that is somehow they feel that the cirrhosis is much more common, the liver is more damaged, and looking at the surgery with the HCC or hepatitis C virus positive is little different than hepatitis B. So rightfully said, Dr. Hitesh, and we then move gears. Let's put the imaginary case scenario. I wanted to bring in everyone, so I put in a scenario. So let's take 8 centimeter solitary mass lesion in liver. It's HBsAg positive, and there is no other comorbidity. So what would be your standard approach? If I can come to Dr. Hitesh, come again. If a patient comes to you, please.
So basically, the age of the patient, I need to see the liver function test. Then we see the imaging, the ultrasound, a triphasic CT scan. We see the location of the tumor, the degree of the cirrhosis.
So we go slow because many of us will not be very comfortable with all these things. I just want to first put you, is that 8 centimeter pushing you out of the resection part?
No.
No.
No, it's not a contraindication. Many patients who have large HCC will still have a good outcome.
Yes. So first point is,
does not matter.
Okay, what is the size where you'll tell, okay, done, let's do something to reduce
no size limit. It is the location, performance status, remnant liver, quality of liver, everything matters.
So now you have told everything. So in the imaging, I wanted a very specific thing from you before I move on to the whole panel. Is any specific image modality better, a MRI, because you want to look at the vascular involvement, or a triphasic CT scan, which we medical oncologists are very fond of, is good enough? And when the patient comes to you from Viraj, you do not want to do a MR at all.
So usually we do a CT abdomen, and that is most of the patient, it is sufficient. But if you are dealing with a cirrhotic liver, then probably we would like to see more small mats, which is more perfectly seen on an MRI imaging. So usually a CT, but in cirrhotic background, because if there are regenerative nodules, we need to rule out an HCC.
So a MR would be for the small metastatic deposits and probably the vascular involvement. These are two things where you would ask for MR. Otherwise, CT scan is good enough, and you never would ask for a PET scan. That's for sure.
No, it's not FDG avid. So PET usually is not done.
Yeah, so I'm telling this because of my friend, because the benefit of my medical oncologist friends. So there are a lot of things in HCC which are so different from what we always deal with other cancers. So for vascular involvement, is it a contraindication? A very quick yes, no, or let me complete. Or if there is a vessel number 2 or 3 in the portal vein which is just thrombosed, that is fine till the main portal vessels are not thrombosed. If it is operable, you would like to operate.
Yes, I will still go for surgery. If it does not go into the other side, if it is resectable, we'll straight away resect.
Viraj, do you agree to this part? Because we are so strict on this vascular involvement portal vein, because this is a very dicey criteria. There are criteria where you can operate, but still lot of the consensus is if there is a portal, that's a vascular involvement of some sort, surgery is usually not done. What is your take on that?
So I agree, main portal vein, I don't think so any surgeon would operate. But segment portals, I think so more and more surgeons are operating. And I think Dr. Soin has the largest series where the segmental vein thrombus, they eventually turned out for surgery and then had an improved survival.
Okay, so this is again something which I feel the world is changing with the techniques, with the post-op cares, all our surgeons getting more skills. This is something which they have evolved over it. So Dr. Hitesh, last point, portal hypertension. Is it a contraindication, or if it's a mild portal hypertension, still you'd go ahead and operate?
Yes, see, usually we don't do HBPG, but we look at the liver function test, platelet counts, the INR. We do a preoperative upper GI scopy. We see the size of the spleen preoperatively, presence of ascites, collaterals. So this will broadly give us an idea whether we should go ahead or not.
So idea is that if there's a good amount of portal hypertension, don't do it. If it's a mild, you would not, you're looking for it, so you'll operate anyway. So this is what you spoke of. In a cirrhotic, it will be something like 30 to 40%, in a non-cirrhotic 20%. Let's take it that that's what your guidelines is also. Okay, now we come down to, would you ever send a case of any case of HCC, which is let's say 3 centimeter, 4 centimeters for a RFA? What is your preference, RFA versus a surgery?
See, if the performance status is good, if it's easily operable, if I think that patient will tolerate the surgery well, then I will always give him option of.
Where I'll ask in different way. Where would you send a patient for a RFA in a 3 to 4 in a 3 centimeter lesion? Let's say.
No, he will still go for. I mean, RFA. Usually, we send the patient for RFA when, suppose if we are bridging him for transplant, then I would prefer not to operate him.
Okay.
You know.
So that is one area.
Yeah. So, but otherwise, operable lesion, even small lesion, we would still prefer to do a surgery. And many of them are peripherally located lesions, can be done actually with minimal access surgery.
So that's where we stop for now, and I'll come back to you in a different case scenario. Dr. Viraj, now coming to you, the cases who come to you or your team, which is your case whom you would like to, who has come to your OPD first for a RFA versus a surgery, and the tumor size is 3 centimeter. I'm not going for larger tumors. This is something which I need a perspective.
So as a medical oncologist, I never decide RFA versus surgery.
What do you feel the criteria would be?
So medically inoperable, and like sir said, if patient is going for transplant, you don't want to operate him twice. Otherwise, resection nowadays, it's like Hitesh sir is also doing laparoscopic. So I think so easy resections, if it is possible, I don't see RFA can substitute.
So this is what the evidence is. This is from a 2021 article, a very nice article in Nature Publications. And this is something that just out the whole locoregional area. If we look at the RFA versus rest, yes, the consensus is if it is a childhood's A, the liver is not compensated in any form, you have a very good performance status, probably surgery is the way people go ahead. But otherwise, if you look at the trials, there's nothing much to choose. Both the things have looked around the same. If the patient is eligible for the RFA, I expect the size to be around 3 centimeters, except for the Chinese trial, which is looking at a little bit of poorer outcome to the RFA. And the locoregional control is definitely poorer with RFA because surgery definitely takes care of the micrometastasis, which is around the margins, which is already visible on the tumor. So this is again the RFA versus the ethanol infusion versus the microwave. Nothing much to choose about this technique. So I move on. So Dr. Viraj, are you a fan of combining locoregional treatments with a systemic treatment in any sort?
Short answer, no.
No. So short answer is no. Rightly, none of the trials, at least with RFA, has shown that if it is superior to the RFA alone. So last question, and then I move to the real cases of the B type of cases. So now resected margins, any adjuvant therapy options, TACE or Sorafenib, anything? No?
No, I don't.
This was a negative, yeah, this was a negative trial, Viraj. 4 years, Sorafenib. Yeah. So there was a criticism that probably this was because the dose was much, much higher than what a patient would tolerate for 4 years. Do you think the trial was done at a lower dose for 4 years? It would be any different?
No, sir, I don't.
Okay. So at this point, the take-home message is, if a patient is of a good performance status, operable, size is not a contraindication. Many times we medical oncologists, radiation oncologists make a lot of view about size, us medical oncologists. But for surgeon, if the liver is good, the liver is not damaged, it is CPS-A, they would like to go and give it a try for surgery till there is a major vessel involvement, major portal hypertension, that is something. And once they have operated, there is nothing as adjuvant, although the TACE is finding some evidence, which is a weaker evidence, but nothing as a TKI. So I'll move down to, let's get my 2 radiation oncologists in, and then let's move forward. Now, Dr. Rohit, sizes, any specific, because Dr. Hitesh told nothing. I will do and operate everything that a patient is eligible, and size is not a matter for me for liver resection. Transplant is a different setting altogether. Anything for you in SBRT?
So basically in SBRT, am I audible?
Yeah, please. You have loud and clear.
So basically in SBRT, we get patients who are not suitable for surgery.
No, I would like to you be specific to this point. Size, is it a concern? If it's a concern, beyond what size would you not consider SBRT?
So basically the thing is, up to 8 centimeters or so, we are quite comfortable treating with SBRT. So the thing is, the difference is in the way we give the doses, the way we do the planning, and the thing is the probability of local control. So if you are 3 centimeters or less, we have a probability of local control at 1 and 2 years in the region between 90%. Whereas if the size is more than 3 centimeters, then we are looking at a local control at 1 to 2 years. With SBRT alone, anywhere from 60 to 75%.
Okay, so basically what I get to know from the radiation oncologist, the evidence is not there in the level 1 type. We would go for something who is not medically operable, is not probably fit for other modalities locally. Then you think of SBRT. A size of around 5-6 centimeters, probably what the books tell, but you get me that 8 centimeters also fine for you. Because I had the idea that till 6 centimeters, it was okay.
Can I add something? Yeah.
Please. Yeah, please.
Yeah, I'm a radiation oncologist. It's actually, mainly it depends on how much normal liver we can spare. That is more important than the size of the tumor. And there is a concept called effective volume. That is the volume of normal liver, how much it is getting. Depending on that, we can decide how much dose we can give, or at all we can treat or not. So it's
if the dose
important.
Okay, I got it. So the toxicity to the remaining liver is important. That's what I'm getting it.
Exactly.
But I always had an idea that you would not be able to sterilize the tumor completely beyond a particular size in radiotherapy. Is it a wrong concept of mine, or is it something that is true?
No, it's not completely wrong, but it's more dependent on the normal liver that we can spare rather than the size of the tumor.
Okay,
because it's a parallel structure. Yeah.
Okay. Compared to RFA or compared to TACE, is it that in radiation oncology is the SBRT technique in where most of the livers are like SBRT? Is it that the best criteria for it is a medically inoperable who is not fit for any locoregional?
Yes.
Or what is your experience on repeat TACE? Something that TACE has been done once and then SBRT comes in at the second time. Anyone has any experience on this?
Probably in recurrence after TACE, we'll go for SBRT. I don't think we'll send for repeat TACE.
Okay, so that we will come to that. The repeat TACE part is something we'll come to. So am I getting, can I ask something, both of you? What has been experience with FCC with SBRT?
Yeah, so we have submitted our data, like I was in Apollo Hospital, Hyderabad previously. So we have submitted our data of around 56 lesions, and it is under peer review. And so follow-up is not long. It's around 1.5 years follow-up.
Can I ask you 2 things here? In your 56 patients, what is the maximum size around? What the median size of the tumor?
Yeah, that median size, as far as I remember, was not more than around 3.5 centimeters.
Fine. And what has been your response to the tumor for a 3 months old MRI post SBRT.
Yes.
You would have definitely done that.
Yes, so local control was good. Local control was around 80 to 85%.
Okay.
But mostly the thing record is actually in other areas of the liver.
Okay. So basically, that's what the take home is, that radiotherapy is still not ready for prime time. It is still going to be surgery or a transplant or the TACE or TARE which you're going to speak. And definitely the role of the systemic therapy is little bit upper. Probably the stages are different. But there is one interesting study which is being quoted long now in multiple papers. This is the SBRT and TACE together, which was compared to Sorafenib in macrovascular involvement, because this is the area where probably systemic therapy is getting as a standard of care. Although Sorafenib probably at this point would not be the major focus for us medical oncologists, but with this comparison, the 12-week PFS was 86 versus 34. Impressive. And this is something that as a paper has been published, and this is probably giving an idea to combine treatment modalities in the locoregional part. So let's come to this case scenario 2. This is a 57 years old, hepatitis C positive. There are 4 lesions, all restricted to one lobe. The sizes are there mentioned, 4.7 to 3 centimeters. That's the average size. Quite big. Dr. Hitesh, no vascular, no portal complications. The CPS is B. We have a score of 7 or 8, let's say 7 at this point. What next? Would this patient for you be eligible for a surgery, number one, or would you take it for transplant? Or would you not consider both and send it to the next panelist, which I'm going to go through, Dr. Gandhi, for his opinion?
This patient probably doesn't go for surgery because multicentric lesion and is beyond transplant criteria. So the best modality would be to give locoregional therapy, TACE, and downsize. And if it responds, then probably to work up for transplant.
Okay, so now, Dr. Gandhi, I think we bring you in now, Dr. Rosal. So for you, it is TACE? Dr. Rosal Gandhi is here?
Yes, he is there.
Yeah. Hi, everyone.
We cannot do this panel without him. So he has to be there.
Yes, after the surgeon says no, I come into the picture.
No, you have to fight for your space. The surgeon cannot let you take your space. So please tell me. So I'll come to your different questions. So even these modalities, the surgeon has taken out resection transplant. So first thing to you, it is a TACE or TARE, point number 1. And if it's a TACE TARE, would it be with Viraj's combination of a TKI, or the radiation oncologist have told, भैया आप तभी भेजो जब आप लोग नहीं कर पाओगे तभी हम लोग करेंगे. That's the very clear idea but I got from them. So what is for you, a TACE or TARE?
For me in Gujarat, TACE is the first option because the TARE is not available. And
you have the availability of TARE. Now answer this.
Then TARE is the ideal thing. It's the first choice.
Viraj, agree, disagree?
No, why? I don't know why. Why TARE?
Okay. So yes, why TARE? Rightly put, because I've given you everything that is for a TACE.
Yes.
TARE has a better necrosis rates than TACE.
Can I make it more simple? Do you have a level 1 evidence which pushes you to use TARE in this scenario?
Or even level 2?
Yeah, level 2. Dr. Hitesh, would you be confident? Yeah, would you be confident to do a TARE? Would you, because you are involved so much in this area than all of us, would you be very comfortable with a TARE in this case?
No, we will do TACE.
Okay. So now there is somehow I thought I will get Dr. Gandhi up and going that, okay, this is my case. But somehow he has let go and I will just come back to him. And I'll ask Dr. Hitesh why he was so much good enough to spare this case. I'll give you some evidence for this and I want his opinion. This is a beautiful meta-analysis that has come up in 2018. We have all criticism of this. This hepatic resection compared to chemoembolization in intermediate to advanced stage HCC, a meta-analysis of high quality studies. It's a beautiful thing which has come up and let us see the data and I want your opinions. I've just put forward this. This is there in the Hepatology Journal. And if you look at the B and C types, the BCLC-B and BCLC-C, and look at the hazards in favor of resection, it is 0.56. And look at the C also, if you select the patients well, it is 0.53. And just go ahead, and if you look at the 1 year, 3 year, 5 year survival, and all the blue circles are for the surgery, and all the lower gray is for the TACE. Looking at a meta-analysis, looking at the high level quality and the hazards of 0.6, does it not feel you would inch towards fighting for these cases for a surgery, because these cases included B and C variety of the Barcelona clinic criteria? What is your take on this? Or do you think it is just a suggestion to run a clinical trial?
No, we have had experience of doing such type of cases, but the selection is very important.
Yes.
Where the location, what we are resecting, remnant liver, etc. And patient should accept recurrence, whether there is any possibility of him going for transplant, whether he has a live donor. So all this matters a lot. If the patient tells us that he doesn't want transplant, and if it's fit, if we can resect, we have done resections by lobar, even recurrent HCC, multiple HCC, they all do well. So it depends on all these factors, and then we select the patient. So patient selection is very important when we talk about intermediate HCC who are resectable.
So the feeling I'm getting now is we have shifted grounds a little bit to a surgery that if the patient is not eligible for a transplant in the near future, then the bridge therapy really, downstaging therapy really gets out. And that is where you probably can push for a surgery if it is feasible and fits your criteria. Am I right in phrasing this word this way?
Yeah, and other important thing is that the background liver. See, if a patient is having cirrhosis, he is definitely going to have recurrence. And even if non-cirrhotic liver, they will have 100% 10-year recurrence. So if you compare transplant versus resection, transplant is still better if he is downstage. So all these criteria matters. So patients should accept recurrence, and all these factors are important. When we
Dr. Amish, I understand. Dr. Amish, the size, if I can get it right in the article, was around 5 to 6 centimeters. There are multicentric lesions also because they included B and C. Viraj, what is your take on this study now?
I agree with Dr. Hitesh. If this patient, I would push for transplant if he can afford and have a live donor. Then do a neoadjuvant TACE and then go for transplant if he responds. Surgery in child B, patient has to be very, very counseled that he's going to fail soon. This patient is going to fail soon.
Okay. So I'm bringing this very important point now that surgery and transplant are so very important. When you look at multicentric liver deposits, we somehow feel, come on, let's get the Atizo and the BEV data in. That's where we jump into. And when you get into and look at these things, if a patient is eligible for a transplant, probably has that donor or something which you can push into a transplant program, there is the feeling that all the experts are telling, push for a therapy like TACE, downstage it, and then probably this will be, this is what it is. Dr. Amish, it is not bridge. Bridge is something that will come down. I have a question for that because the downstaging and bridge are two different definitions in altogether. So now coming down to again, Dr. Gandhi, in a TACE, let's say that the patient told Dr. Hitesh is ready for a transplant and he sends it back to you, and he told Dr. Gandhi, please do a TACE. Can I ask you, because like novices like us, how many times do you do a TACE? Is it 1 time, 2 time, 3 time, 4 time? And you do it in how do you do it? And how do you define TACE refractoriness? So that is something I think that should be a take-home message also.
Yeah, I have done TACE twice, but I've seen people doing TACE 3 times also. As long as the LFTs are good and the patient's general condition is maintained, good. We can opt for a repeat TACE to control the disease.
Okay. And any definition, how you define whom not to do a TACE refractoriness definition? No. Okay. So that's fine. So what the books have defined and the newer journals have defined is, if there is less than 50% or more than 50% residual tumor after 2 TACE, that would be considered a refractoriness. and or if there is a new lesion after 2 is also what they're looking at. So these are 2 things which I'm looking at. And Dr. Amish, here comes your bridge and downstaging. I just put this one. Dr. Viraj, can you tell us where would you define as a bridge and where do you define as a downstaging?
So bridge is a treatment where you are waiting for a transplant. You are actually operable right now. You don't need to shrink your tumors. And the downstaging is the latter, where you need to shrink it. And only if there is a response, then you proceed with a curative resection in form of transplant.
Yeah. So basically what is happening is bridge is where the waiting list is long enough. They want to give something. If they've given Sorafenib, even they're given the TACE. What they've done is it has not actually made a difference in survival. But while downstaging, it does make the patient eligible for a transplant, like you do not fit into the Milan criteria or the UNOS criteria, and then you downstage to make it fit into the fitting criteria. And there is a difference in the downstaging, the 1 year and 5 year survival. So that is the difference. Basically, you make someone eligible for a transplant is the downstaging. This is something which is very interesting for people who are into, I think all of you would know for completion's sake. This is the things how people look into doing a retase or not to do a TACE again. There's the ART score where they look at the radiological tumor response. They look at the AST increase beyond 25% and the CP score, which is increase in the CP score, not the CP score itself, the baseline and the increase. And what they did was, and if you had an increase of more than 2.5 points, you do not take the patient up for a retase because there is a deterioration in liver functions, as our expert told here, Dr. Gandhi. And what they found that if the score was high or the low, that does make a difference even in the survival. So that is something that has come up. Even there is a good data that there is different scores actually, 3 or 4 scores are different. One data is that alpha fetoprotein if it's still high, the BCLC if it is higher stage, the Child-Pugh if it is increased, or there's a tumor response is absent. Again, the scores are the poorer the prognosis, the outcome of retase is poorer. So people do not try to do it. So this is where I will stop here. So can I ask, let's say Dr. Gandhi first and then Viraj, probably. A TACE versus a depth TACE. Do you feel there is a difference? Eluded beats, you do it versus a TACE. Dr. Gandhi, your opinions, and then Dr. Viraj.
Yeah, drug-eluting beat TACE is better than a conventional TACE.
Can you tell us in which regards it would be better?
The side effects are less and the necrosis rates are also higher than a conventional TACE.
Viraj, agree? Yeah, please complete. Dr. Gandhi, please complete.
The beads tend to keep slowly release the doxorubicin over a period of time, and that gives a more necrosis.
Dr. Viraj, your take on that? A TACE versus a depth TACE.
I'm not aware, sir. I Rosal or Milan Bhai in our Gujarat, these 2 people do TACE.
Okay. So basically, he's right. There is not much of a difference actually in the response and the oncology outcomes. It is majorly the outcome of the toxicity. The depth TACE is considered to be a lesser toxic than the TACE itself. The TACE and TKI versus TACE, Viraj, your answer is same again?
So TACE,
or would you,
TACE alone.
TACE alone. What do you then think of the study, the TACTIS, which is there? Why do you think it was a positive study? And what is your take on it?
That is the tactics 2, you mean, right? The tactics
is
the only positive study.
This one,
which was presented this year GI ASCO.
Any take on this? Is it practice changing? If no, why?
No, I don't.
Okay, so basically, what it tells, if we go to they went on doing TACE in spite of having a new disease. If it was TACE, if TACE was doable. So that probably made this Sorafenib going on for a longer time to 37 months. So that was one of the things that is normally not a practice, because TACE you don't do when there's a new lesion. But the take-home message is what Dr. Viraj told. We would look at the data more carefully. We lead more trials, and TACTIS, to be fair, was a phase 2 trial. It was not a phase 3 trial.
Yeah, now I remember. So this counted PFS in a different way as compared to. So strategically avoided calling them a progression if there was new lesion and continued the disease, and hence the PFS seemed to be improved.
I'm sorry, I'll tell you, to be fair to Viraj, he was not a part of the panel because both the medical oncologists dropped out. he's there as an organizer to fill up the panel.
No.
So yeah.
But I don't do it in my practice. TACE plus Sorafenib.
Yeah. So I think we as medical onc have to know the systemic therapy part, and I think this was why the PFS was little higher. That is why, because the continued TACE in spite of new lesions, that is why what Viraj told, that it goes on, and that is why it is that the PFS was longer. So this is what I spoke of the space. I'll go through the last case scenario and stop because I have 10 minutes more. So Dr. Hitesh, and then I go down to my radiation oncologist. Dr. Hitesh, now this is the lesion. The first one you definitely told no. If it is a transplant eligible, you'll take it. Do we take it that this is not at all transplant eligible or not surgical patient? You just refer it to the other guys?
Yeah, this is not resectable, and I mean I need to see the scan, but looks like that we need to give some locoregional therapy before we do something.
Okay. So now, if there was a portal vein thrombosis, I put that there was nothing, but now there is portal vein thrombosis. So, Dr. Gandhi, would it be a TARE or a TACE with a portal vein thrombosis?
With main portal vein thrombosis and bilateral lesions, TARE.
Okay. So now we are on the same page. I think now it is a TARE. Normally it is not a TACE. So Dr. Rohit and Dr. Paul, I showed you the data of such lesions, that impressive 12 weeks PFS of 80% with radiotherapy and TACE. Would you not fight to take this patient for a TACE and radiotherapy with SBRT? Because that data was impressive. What is the take on that? Have I lost both the radiation oncologists?
No, I'm there. I was waiting for Dr. Rohit's response. So
Please,
in this
please.
case,
There are
like
5-6 lesions, there are quite a few lesions.
yeah. I'll not be very much comfortable treating.
I'm not comfortable either.
Yeah.
Okay, so now both
up
are
to 3 lesions, I have done it. Up to 3 lesions.
Okay. Up to 3 lesions you have done it, and up the size is probably a relative contraindication. That's the idea I've got, except for the liver toxicity also is something which you need to look at. So here it is a TARE and TARE alone. Dr. Viraj, this is an area where the systemic therapy does come in. Most of the recommendations are in such cases, systemic therapy is also an option. Right. What is your take on it? Should you do it a TARE, or should you do it as a TARE plus TKI or a TKI alone?
So I agree. All the intermediate risk patients were 20 to 25% in all our systemic trials. So it's not wrong if we consider systemic treatment. In Gujarat, we don't have TARE. So for me, it becomes very easy decision. This patient goes on systemic treatment.
Okay. So because there is no TARE, this becomes easy decision. If there would have been TARE, would you have gone to a tumor board and discussed each case out?
Perhaps, yes.
Okay. So this is where these studies are, the TACE versus TARE versus systemic therapy. And again, the same article, a beautiful article. I can share with whoever wants it. It's a Nature publication, a nice 21-page article. It was if you look at it, the TARE versus Sorafenib data, there are 2 studies actually, and these studies have been spoken quite often. There is a TARE and Sorafenib with versus Sorafenib, nothing much to choose between them. But if you look at these 2 studies and look at this, the SARA and the other one, there was no difference actually between the TARE versus Sorafenib on head-to-head comparison. So the expected outcome was that TARE would be superior, but luckily for us, unluckily for the patients probably, the TARE did not stand up to the survival data. Now, Dr. Viraj, do you feel,
luckily for patients also, because we spent 10 lakh rupees.
So this is the data, and I can tell you the Soramic trial, which was with the yttrium microspheres and Sorafenib versus Sorafenib, also was a negative trial. So the take home here is for the and look at this. These were unresectable patients, PS more less than 2. They were actually PS 0 to 1, and this was 8 up till B7. So all these trials was B7 and below, but in our practice, we get everything beyond B7 actually. So that is also something we need to look at in system therapy. But to be fair to us, this data gives us confidence that in such patients, even a systemic therapy would be there. So do you think, Viraj, I come to you in the last, if this would have been Lenvatinib, and all of us know the response rate is slightly better than Sorafenib, would these results be very different? And do you think this is high time to include the immunotherapies into versus this TARE business?
I agree, sir. And you know my position from various times that we as a medical oncologists are moving towards left. We are creeping towards intermediate B. And I agree, because it was Sorafenib, you are seeing same. If you do put more potent drugs like Atezolizumab or Lenvatinib, I think TARE would lose hands down.
And to add to that, a lot of studies are going on to include immunotherapy along with the locoregional treatment.
Along with it.
Yes, along with that. So my point is, this area is looking very interesting. I think in 3 years, this will be as interesting as lung. The breast cancer is losing out on the interest of all of us probably. So this is the area of interest. So look at the guidelines, my last 2 slides. Locoregional therapy is preferred for what we spoke. And if I take home the message, what it should be is surgery and the transplants are one of the most curable. All the treatments apart from this makes the patient incurable. So surgery and transplant is something you should always have a hepatobiliary surgeon in the team. Take his opinion, include him in the discussion, and that is where patients will be cured. Beyond that, everything is palliative. You can increase your survival, but cures are not happening. That is take-home message number 1. Take home, the liver functions is so very important. If you do a TARE, it's important that you go on doing a TACE. Or TACE, you go on repeating the liver function. The deterioration is so fast. And to make very things simple, only 30% of patients following a TACE actually receive systemic therapy because the liver has deteriorated so much. So do not overdo TARE also. That's something very important. You have to relook at the patient after 1 to 3 months of a TARE. If the response is not happening, shift to systemic therapy quickly rather than going on banging the patient with more TAREs. Number 3, as a TACE, sorry. Number 3, TACE and TARE. The thrombosis is something that is very important for us to differentiate. If there is a thrombosis, it is a TARE. And if there is multicentric, multi-bilobar, it is probably going to be a TARE. And systemic therapy is pushing in. Wherever anything fails, then there is a systemic therapy. And we are also going for and combining both the therapies. And SBRT is coming prime time. It is going to be one of the main armamentarium. I think patients who are not medically operable cannot go ahead to do the locoregional treatments. SBRT is there, and probably it will be also along with the TACE. That trial which has showed TACE and the SBRT trial is very encouraging. So this is what it was. I will just last slide of mine for a guidelines which is published by the Pan Asia adapted ESMO clinical guidelines. I put it for 2 reasons. It is for our region. Second, I could find the name of Dr. G.S. Bhattacharya, and this was his public. He was part of this guidelines. So I thought it appropriate to bring it and look at it. If it is a BCLC-B, multiple nodules, more than 3 centimeters, 2 to 3, TACE is something that is very, very important that we discussed. Liver resection is something that we already have discussed, and I think this panel will give the importance which is due to our hepatobiliary surgeons, because we sometimes forget them because we do not have their, like in Bhopal, we do not have them actually. So now we come down to more than 4 in B. In the B, TACE is again the standard of care. Resection should be considered, and if patient is eligible for transplant, you should downstage and then give it for transplant. For C, actually, that's where systemic therapy is creeping in, probably taking over TARE for 2 reasons. That is, the trials have shown it is not inferior. The systemic therapy is equally good, and TARE is equally costly. That is something that is probably, that is where the systemic therapy is going to pitch in and come in very, very fast. So with that, I close my panel, and I give 1 or 2 minutes to the panelists. If there's something that is missed in the locoregional therapy, they can please come in. I can just start with Dr. Hitesh. Any points, sir, which you want to highlight?
No, I think we had a fantastic discussion today.
I have a point.
Yeah.
If, sir, you would agree, Dr. Soin presented last month that they do PET scans for all of their cases. You remember that talk, right?
Mm-hmm.
And so, like Dr. Sahoo said, PET scan is not something as a medical oncologist we are more used to for HCC. What's the purpose of using PET scan when you want to downstage, or what was the reason? Dr. Soin has a large series, right? On
Viraj.
PET. Yeah.
This was for patients who have portal vein thrombosis and whom they have downstage to make them downstage to transplant. So they have used PET scan, they have used SPRT, they have used TARE, as well as Sorafenib. And once the lesion and the thrombus become FCG non-avid, they explore them and then do transplant. So this is how they do. So they have a large series now.
Yeah.
I think Viraj also, I think these patients, when they, the type of patients they're telling, they would also like to exclude the extrahepatic disease. And PET does give edge on the extrahepatic disease. They don't want to do a transplant for anyone who has extrahepatic disease.
Right.
I think that also would be something. And that point of the uptake is important. That's quoted in the trials actually. The MR versus PET debate is ongoing, which is a better modality for the necrosis part. I think that could be one of them. Any other point that is left? If no, thank you, Viraj. Thank you all the panelists. Sir. I love